Good morning to lecturer and fellow friends. We are from Group 1B and we will be presenting our surgery and infectious disease related to infectious disease. In this case, the patient is 36 years old male which have come to the hospital with the chief complaint of neck stiffness and fever for 7 days. For the past week, he had developed ear pain, mild fever, and headache with the inability to tolerate loud noise. Then he also developed symptoms such as neck stiffness and high-grade fever. The patient claimed to have lost weight over a few months and had previously hospitalized due to the poor blood sugar control. Moreover, he had no known family history and is an active smoker for the past 15 years. For the past medical history, the patient had known allergy toward penicillin and also have underlying medical conditions such as diabetes mellitus, mild hypertension, bronchitis, appendicitis, hemorrhoid, fractured femur, and splenic injury following motorcycle accident. For the past medication history, the patient is currently on metformin, glibenclamide, metoprolol, and also theophylline. This is the lab investigation of the patient upon admission to the hospital.
Possible drug-related problems would be he is known for allergic to penicillin. The patient do have uncontrolled blood glucose level due to adherence issue to the medication. He do experience high risk of resistance to insulin due to smoking habits. It seems there's a moderate drug interaction between the metoprolol and theophylline, which reduces the metabolism of theophylline. And finally, the moderate drug interaction found to be between the beta-adrenergic blockers and antidiabetic agent that has been prescribed for this patient.
Moving on to the next part, patient was diagnosed with meningitis after presenting to the physician with clinical signs and symptoms suggestive of meningitis. Basically, meningitis is a clinical syndrome characterized by inflammation of the meninges. The risk factors for the development of meningitis seen in this patient are the underlying chronic condition that are susceptible to the infection, such as diabetes mellitus and renal impairment, and smoking. The signs and symptoms shown by these patients include febrile, rapid labored breathing, as well as neck stiffness. The most striking lab results that support the diagnosis of meningitis are the markedly increased CSF cell count, which is 90% neutrophil, increased white blood cell, elevated protein and lactate level, as well as decreased glucose.
Now I'm going to talk about the empirical therapy for bacterial meningitis. Empiric therapy shall be started before CNS result is obtained. For bacterial meningitis, ceftriaxone or cefotaxime are the drug of choice. However, this patient has history of penicillin allergy. Penicillin may have cross-reactivity with cephalosporin, thus it is best to avoid the use of cephalosporin in treating this patient. According to the National Antibiotic Guideline, the recommended alternative drug is chloramphenicol 1 gram IV every 6 hours. This empirical therapy should continue until the CNS result is obtained, then switch to the narrower spectrum based on the specific gram stain. Adjunctive dexamethasone 10 mg IV for every 6 hours shall be given 15 to 20 minutes before or at the same time as the first dose of antibiotic. Continue for 4 days if gram stain consistent with the Streptococcus pneumonia. This is to reduce the mortality and morbidity in bacterial meningitis by blunting the inflammatory response secondary to bacteriolisis. In addition, paracetamol 1 gram for every 6 hours shall be given to reduce the fever and to relieve pain in this patient.
Pharmacy intervention for this case. First is through de-escalation therapy, in which narrow down the spectrum of the antibiotic to avoid the development of the antibiotic resistance. This intervention must be done after we obtain the CNS result. Second is through switch therapy, in which pharmacy be able to switch the route of administration of the targeted therapy from IV to oral once the patient becomes stable. Third is through the assessments of the discontinuation of the dexamethasone when the causative organism species are other than Haemophilus influenza or the Streptococcus pneumonia. Fourth is through monitor regularly, in which monitor the effectiveness and safety of the antibiotic regimen given based on the patient's clinical condition. Fifth is to assess the appropriateness of the current medication in management of diabetes and hypertension, since upon administration, the blood pressure and the blood glucose level was uncontrolled for this patient. Sixth, the intervention that can be done is dose adjustment. It seems that the serum creatinine level is high and suspected to have the renal impairment for this patient. So we need to take the height and the weight for the patient to calculate the creatinine clearance for the proper dose adjustment for the metformin. Lastly, to the educate patient, as the patient is heavy smoker. So we need to educate the patient about the smoking cessation program, because smoking is one of the risk factor that could worsen his hypertension condition.
The next part of the presentation is the monitoring plan. We need to monitor the efficacy and safety of the treatment plan, where monitoring parameters for the treatment efficacy include first, the vital signs, to check the body temperature, blood pressure, pulse rate, and respiratory rate. Second, to monitor any clinical improvement in the signs and symptoms. Third, the WBC count. Any reduction in the WBC may show positive response to the antibiotic. And fourth, culture and sensitivity tests must be conducted to initiate a narrow spectrum antibiotic therapy. Next, the safety parameters. First, complete blood cell count must be conducted approximately every 2 days after the baseline, since chloramphenicol may cause several blood dyscrasia. Next, blood glucose level to monitor any signs of hypo and hyperglycemia. We must also check for patient renal and hepatic profile, and to check the level of serum drug concentration as a safety measures.